Welcome to the Winter Hematology Update. My name is Dr. Eunice Wang, the Chief of the Clinical Leukemia Service at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I am delighted to be here today to discuss updates in AML from the recent ASH meeting in December 2021. What's new in AML? Well, what we have seen at the most recent ASH meeting is combinations of a number of different agents which have been approved for the treatment of AML over the last 3 years. We also saw that there was some refinement of how to use some of these combination therapies. And we saw the advent of a few really novel agents, novel biological targets, and immunotherapeutic avenues to treat this disease. So a lot to cover in this talk. My talk will be divided into first discussion of therapies for fit or younger individuals, followed by options for older and unfit patients with AML, and we'll end with a few novel, intriguing agents which piqued my interest at this year's meeting. The first thing I'd like to start off with is some landmark data demonstrating how much progress we've made in the last 3 years with the advent of a lot of different agents available. Lancet and colleagues presented this 5-year update of the results of a phase 3 clinical trial comparing the use of CPX-351, liposomal cytarabine and daunorubicin, as compared with standard cytarabine anthracycline for the treatment of a poor prognosis subset of patients, those with secondary MDS-related AML or therapy-related AML. As we know, liposomal 7+3 is now the standard of care for those patients with AML, MRC, or therapy-related AML, but this trial provides a long-term snapshot of what we can expect for some of our patients, particularly those who have the opportunity to achieve a response with this therapy and go on to subsequent allogeneic stem cell transplantation. As you can see here on the left-hand side is the data showing 5- and 3-year survival rates for patients who achieved a CR or CRI on this initial phase 3 trial. As you can see, 30% of individuals who were randomized to the CPX-351 arm are still alive at 5 years, as compared to 19% of those who were in the other arm. 3-year survival was similar, 36% versus 23%, with a significant hazard ratio of 0.59. Most intriguing and probably most impressive to me was the overall survival in those individuals who had achieved a complete response of some sort and had subsequently gone on to allogeneic stem cell transplantation. In these individuals, the 3-year overall survival following CPX-based therapy was actually an astounding 58% as compared to 29% receiving 7+3. And this data is demonstrating that for a significant population of patients, about up to 56% of patients were alive at 5 years following CPX-351 and stem cell transplantation. This demonstrates for us that we are actually able to achieve long-term cure for this poor prognosis subset and gives us hope that we can further improve these outcomes for other poor prognostic subsets of AML. How can we move this bar forward? Well, there was this trial, which is presented by Kadia and colleagues from MD Anderson, showing their data combining CPX-351 with another agent, venetoclax, an oral BCL2 inhibitor, that we're more used to seeing in the upfront setting for older and unfit individuals. The theory behind this trial was that if venetoclax can overcome chemoresistance to azacitidine and enhance the outcomes of azacitidine, can it enhance the outcomes of other foundational chemotherapy regimens? As we can see here, this phase 2 trial enrolled both relapsed and refractory AML patients in cohort A, as well as newly diagnosed patients in cohort B, with the primary aim initially to assess safety and tolerability of different doses, and then to look at measures preliminarily of efficacy. What these investigators found, as we would expect from those of us who are familiar with the use of each agent as a single agent, was that the combination of CPX and 351 was really limited by significant myelosuppression. And you can see here that at the initial dose level, there was prolonged myelosuppression, and then they subsequently had to dose reduce further because they had an additional patients with prolonged cytopenias. And the combination appeared of CPX-351 with 20 days of venetoclax appeared to be something that really was not going to be feasible in the long term. So the investigators did make some dose adjustments. They presented data, did these patients, even though they had prolonged myelosuppression, achieve remission? And again, in this very difficult to treat patient population, they achieved an overall response rate in those patients who are evaluable for response of about 44%, with the CR/CRI rate about 39%. The mortality rate was 10% in the first 4 weeks and 20% in the first 8 weeks. And about most encouragingly, for these patients that had poor prognostic disease, the importance of being able to transition them to allogeneic stem cell transplantation can't be overstated. And the investigators were able to demonstrate that almost all patients, 88% of them, were able to eventually transition on to that allogeneic stem cell transplantation. Now, why was the CR rate so low, or why was it less than expected, even though we had a lot of myelosuppression? Well, what seemed to make a big difference in the response of patients to CPX and venetoclax combinations was whether patients had received prior venetoclax, and none of the patients who achieved a long-term remission had prior venetoclax therapy, and the median overall survival of those that did have prior venetoclax was only about 5 months. So something to be aware of. Other investigators also at MD Anderson have been looking at combining venetoclax with another intensive chemotherapy regimen, FLAG-IDA. Shown here is the schema for how venetoclax is combined with fludarabine, cytarabine, idarubicin, and G-CSF, both in the upfront setting and as consolidation chemotherapy. Similar to the last trial, cohorts of patients included those who had newly diagnosed AML, as well as those that had relapsed and refractory AML. Shown here are the preliminary event and overall survival and the small numbers of patients treated both on the phase 1B study, primarily primary refractory and relapsed patients, as well as those enrolled on the 2A cohort, which included newly diagnosed AML. As you can see here in the green lines, event-free survival and overall survival was markedly enhanced in those patients who had newly diagnosed disease. There did appear in the 2 cohorts that had relapsed refractory disease that there were similarly low response rates as compared to the newly diagnosed cohort. So again, 1-year overall survival for the newly diagnosed cohort was 94% as compared to anywhere between 40 to 60%. These do seem a little bit higher than we would expect for some of these poor prognostic subgroups. So we're going to have to wait and see. The amount of myelosuppression with the FLAG-IDA combination did appear to be less than that was seen on CPX, and this combination may be encouraging enough to move forward in some sort of combinatorial approach. Now, we all treat younger fit patients who have FLT3 mutations with a FLT3 inhibitor, specifically midostaurin, but we know that there are more potent and specific newer generation FLT3 inhibitors out there, specifically gilteritinib, which is used in the relapse refractory setting. So that naturally begs the question, can we move gilteritinib into the upfront setting? Can it supplant midostaurin in combination with 7+3? So Prats and colleagues presented the results of a phase 1B trial looking at the tolerability and dose of gilteritinib in combination with a couple different anthracycline cytarabine combinations shown here, daunorubicin as well as idarubicin. Patients went on to get consolidation chemotherapy with high-dose cytarabine followed by gilteritinib, and then were allowed to have up to 26 cycles of gilteritinib maintenance. Overall, in those patients who were FLT3 mutant on this trial, and there were some trials, patients that did not have FLT3 mutation because of the phase 1B nature of this study, the CR rate was about 39% in these individuals, CRI and about another 39%, leading to an overall response rate of a low 80, 81%. Now, a major endpoint for this trial, which is setting the foundation for subsequent phase 2 and phase 3 trials, is a novel clinical endpoint, which is mutational clearance or clearance of FLT3-ITD molecular signal as determined by specific mutational assays. And you can see here that using this endpoint, patients were found to have, with subsequent therapy, better mutational clearance with this regimen over time. So at the end of induction, about 33% of patients receiving 7+ week gilteritinib had clearing of this mutational biomarker. At the beginning of consolidation, 37%, and at the beginning of maintenance, following full induction and consolidation chemotherapy with gilteritinib, over 84% of patients had clearance of this molecular biomarker. Now, we know that gilteritinib has some limitations. We know that in the relapse refractory setting, there's some patients that respond and some patients that don't. So an important question that's been asked by practitioners now was that obviously when gilteritinib was approved for relapse refractory AML with FLT3 mutations, not all the patients were getting midostaurin up front, as is the current standard of care. Only 13% of patients on the Aml phase 3 trial of gilteritinib versus salvage chemotherapy had been reported to receive prior FLT3 inhibitor therapy. So now that we have all these FLT3 inhibitors, how is that affecting what we would expect to see in terms of outcome? So Pearl and colleagues presented updated data from a retrospective analysis of both the Admiral and the initial phase 1b Chrysalis study, looking at the effects of gilteritinib monotherapy in relapse and refractory FLT3 mutant disease. You can see here that they broke out the curves both by gilteritinib versus salvage chemotherapy treatment, as well as by whether patients had received prior tyrosine kinase inhibitor therapy, ideally with midostaurin or sorafenib being the majority of those agents. So what did we learn from this breakout? Well, we saw that overall, gilteritinib was still superior to salvage chemotherapy, even in the presence or absence of prior TKI therapy. As you can see here, patients with prior TKI still benefited from gilteritinib over salvage chemotherapy with a median overall survival of 6.5 versus 4.7 months. However, it is important to point out that patients who didn't have prior TKI therapy did even a little bit better, 9.6 months versus 6.0 months. As you can see, although gilteritinib maintained its benefit, that apparently the use of prior TKI therapy results in gilteritinib responses and durations of response that seem definitely to be a little bit lower than in the TKI naive. Now, what about using azacitidine venetoclax? Could that be something that we could use? And I know that a question that has come up in practice nowadays is for an older unfit patients, do I really have to wait for the FLT3 to come back? Because unlike the fit young individuals where I would add a FLT3 inhibitor for induction chemotherapy, the data on what to treat an older FLT3 mutant AML patient is still out there. We don't know. So there was data presented again in a retrospective fashion by colleagues at MD Anderson, Konopleva and her clinical colleagues, looking at documenting what was the response of FLT3 mutant patients to standard azacitidine and venetoclax without any specific FLT3 inhibitor incorporated into that upfront regimen. As you can see here, venetoclax and azacitidine still did better for these FLT3 mutant patients than those patients receiving placebo azacitidine in terms of CR/CRh, 65% versus 18%, CR/CRi, 70% versus 36%, and in terms of benefits of overall survival. However, when you look at the outcomes of these don't look, the overall survival doesn't look so much better when we looked at the outcomes. When the MD Anderson group decided to say, okay, well, let's look at the combinations and the single therapies. Let's look at different types of FLT3 inhibitors. Can we come up with an analysis of what we all think occurs with FLT3 inhibitor use? So in some retrospective analyses, again, with pooled data with hundreds of patients, they found that patients, again, who were being first exposed to FLT3 inhibitor therapy did the best. They also found, so you can see here, first FLT3 inhibitor therapy, second FLT3 inhibitor therapy, outcomes are definitely improved when you're not pre-exposed. What they also found was that if you combined FLT3 inhibitor therapy with another chemotherapy, either low intensity therapy or high intensity therapy, you had markedly better responses. So you can see here, regardless of whether it was low or high intensity, you were getting about 9 to 10 months median overall survival, combining it with the FLT3 inhibitor as compared to FLT3 inhibitor alone. Similarly, these numbers are about halved when you had prior TKI experience, but again, supporting a combinatorial approach. So based on all of this data, the question then is, can we benefit from the combination of venetoclax potentially with gilteritinib? And this phase 1b study was examining potentially in patients who had progressed following prior venetoclax upfront therapy or prior gilteritinib therapy in the relapsed refractory setting, what the response rate would be when combining two oral targeted therapies. Shown here is the remarkable overall response rate that they achieved, over 80% in all patients, of all 41 patients treated in this trial, and in the 28 patients that had prior TKI therapy, again, an 82% response rate, which compares very favorably to the 52% response rate, which was seen in gilteritinib alone. Shown here is the overall survival in all of the FLT3 mutant patients treated with this combination. And you can see here that the median overall survival is 12 months. And in ITD patients, the overall survival was not reached. And now the median duration of follow-up for this trial was very short, so we'll have to see what happens to these patients long-term and look at the question of whether they are able to go to transplant. But again, this combination seems highly promising. That's led the group to investigate, what about triple therapy? And the data on triple therapy is very scant. We're talking maybe 14 previously treated patients, 16 treatment naive patients, a lot of cytopenias, a lot of infectious complications, but this regimen could be given. And there was some evidence of high response rates, particularly in those patients who had not seen prior therapy. So this combination, again, is still being investigated for its eventual, whether it is worth it. I mean, with an 80-something% response rate with venetoclax gilteritinib alone, do you really need to add the HMA? Not sure. Lots of data out there, but really intriguing combinatorial approaches. What are other subgroups that we still have room for improvement? Well, one is obviously AML characterized by P53 mutations. There was a lot of data demonstrating how poorly these individuals do. Now, the hope was when we introduced other investigational or novel therapies or biological agents, that potentially we would be able to make an impact in this particular poor subgroup. But the data shown here just reemphasizes to us like that venetoclax-based therapy is not the answer for the treatment of P53 mutant AML. And 121 patients with newly diagnosed AML receiving 10-day decitabine and venetoclax. The CR rate of patients with P53 mutant disease was as low as 35%, and the overall survival was markedly less, with median overall survival of only 5 to 6 months. Now, what can we do for those agents? Well, many of us will say, if you have a patient who is identified to have a P53 mutation, what you need to do is prioritize clinical trials. And this trial is one of those that I think of when I have a P53 mutant disease. And this is involving a completely novel mechanism of action than we've seen before. Now, we've looked at immune checkpoint inhibitors. We're familiar with their utility for solid tumor malignancies, as well as for lymphoid malignancies. But we, as of now, have not been able to successfully utilize immunotherapy other than targeted antibody drug conjugates like gemtuzumab for the treatment of AML. That may change. there is this new agent, Magrillomab, which is a CD47 targeted antibody. And what it does is it blocks the expression of CD47 by tumor cells. AML cells do express CD47, and high levels of expression are affiliated with poor overall survival. But we think the mechanism of action is when the leukemia cells express CD47, they are somewhat protected from arms of the innate immune system, specifically immune mechanisms that are mediated by macrophages. So the saying is that the CD47 is what we call a don't eat me signal, telling the macrophages in the patient's immune system that this is a safe cell, this is not a dangerous cell, and that cell then eludes detection and removal by the innate immune system. Inhibition of CD47 by magrillomab allows for the macrophages in the patients to then re-recognize the leukemia cells as tumor cells, phagocytose, and physically remove those cells from the body, leading to anti-leukemic activity. Now, CD47 is also expressed on older or aged red blood cells. So one unique side effect of magrillomab therapy is induction of an on-target hemolytic anemia. This has been associated with clinical consequences, particularly in older individuals that represent a proportion of our MDS and AML patients. And this has been mitigated or needs to be looked out for by transfusion of patients to a higher hemoglobin level prior to administration of this drug. Shown here are the preliminary outcomes of magrillomab and azacitidine in older unfit individuals and not able to get intensive chemotherapy. You can see that among these 43 patients with newly diagnosed AML, the overall response rate of magrillomab combined with azacitidine is a very high 63% and an astonishingly 69% in those patients who had P53 mutant AML. Why do we need to combine azacitidine? Azacitidine actually is synergistic with magrillomab and leads to upregulation of CD47, therefore potentially potentiating the effects of that CD47 antibody. You see here as well that there seems to be no significant difference in overall response rate, complete remission rate, or necessarily in median overall survival with the P53 wild type and P53 mutant. The patients who were P53 wild type had a median overall survival of 18 months. Those had P53 mutant disease. 47 patients had a median overall survival of over 12 months, which is potentially double what we're seeing with any regimen, be it cytarabine-based regimen or venetoclax-based regimen. What about those patients that have primary refractory disease? Can we treat those patients? And there was this data suggesting that a bispecific or an immunomodulatory approach can have some efficacy in patients that have primary refractory AML. The investigators, Aldas and al, for this abstract presented a significant amount of preclinical and correlative data suggesting that patients who are refractory to radiation induction therapy have a unique immune microenvironment, thereby making them more sensitive to an immunotherapeutic approach. Now, this molecule is a combinatorial bispecific molecule targeting CD123 expressed on the AML blast, as well as activating CD3 on the patient's T cells. The major side effect, as we would expect with a purely immunomodulatory agent, would be cytokine release. And this was a significant side effect of this particular floteizumab antibody therapy. As you can see here, 100% of patients receiving the CD123, CD3 DART bispecific experienced a infusion reaction or a cytokine release reaction. 52% of these occurred in the first week when the agent was being successfully dosed increased, and all of these patients needed to be hospitalized for at least 8 or more days. So clearly some logistical challenges. However, in this very, very refractory patient population, there was an overall response rate of about 31%, which we approximate is probably double that what we see with chemotherapy alone in this setting. And a number of patients were able to achieve several months of response before having disease recurrence. Now, the plan would be once these patients achieve a response, potentially to transition them quickly because the durability of the response seems to be a little bit in question, but definitely something that we need to be looking at a little bit more closely for these very refractory patients. Garcia and colleagues at the Dana-Farber presented some data with ipilimumab and decitabine, saying, could we combine an epigenetic agent with one of our more classical checkpoint inhibitors that we use for solid tumors? Shown here, they looked at patients in the relapsed refractory AML setting, interestingly enough, both after allogeneic stem cell transplantation and those who had not yet gone to a transplant. Shown here are their responses, showing about a 19% response in patients who had relapsed after prior transplant and a 56% in patients who hadn't, with definitely some immune toxicity as well in about 40% of patients. Interestingly enough, more potentially in patients or equal to those who had or did not have prior transplant, but certainly a combination that was relatively well tolerated and immune modulatory. I'd like to end with just a new class of agents, which is just starting to emerge on the therapeutic landscape for the treatment of relapsed and refractory AML. And these are menin inhibitors. What are menin inhibitors? Menin inhibitor is a small molecule inhibitor of a menin KMT2A epigenetic complex, which lies at the heart of the leukemic transformation occurring in two specific mutational subsets of AML, AML characterized by KMT2A rearrangements, formerly known as MLL rearrangements, and AML characterized by nucleophosphin 1 mutations. Shown here are graphics demonstrating that when the menin KMT2A complex is activated, it leads to upregulation of transcriptional HOXA9 and MEIS factors, leading to activation of transcription pathways which promote leukemogenesis. Inhibition of this menin KMT2A assay with a specific inhibitor therefore has the ability to block these transcriptional processes and actually lead to what we think in preclinical models is differentiation of blasts to normal hematopoietic cells. The KO-539 is the novel, potent, rationally designed, highly specific menin inhibitor, which binds to this complex at a specific binding site. In this early phase 1 results, this agent was dose escalated from 50, 100, 200, and 400 milligrams in cohorts of 1 to 6 patients based on pharmacokinetic data. As you can see here, this even in early stage testing, there were a few patients. Among the first 8 patients, 6 of them had evidence of some clinical activity, albeit some of these activities were a little preliminary. However, out of the first 8 patients, there were 2 patients that achieved a complete remission. Interestingly enough, 1 patient was characterized by an NPM1 mutation, and the other patient had no NPM1 or KMT2A rearrangement, but was characterized by RUNX1 mutation. Shown here are some of the tolerabilities and toxicities. And 1 patient had a pancreatitis, but the drug was in general relatively well tolerated, and this drug continues in dose escalation cohorts. No modifications as of now have had to be made because of interactions with other drugs, such as CY3P3A inhibitors. So a lot to cover, a lot of interesting data, combinations of the agents that we've had, and for the first time, potentially hope for some valid and novel immunotherapeutic approaches for acute myeloid leukemia. I appreciate you taking the time to listen to me today. I hope you found this helpful, and I hope you go ahead and enjoy the rest of the Winter Hematology Update on the ASH 2020 meeting. Thank you very much, and if I can be of any assistance, please feel free to reach out.